morning to you. It's very chilly right here in Nairobi, so I hope that you're keeping warm wherever you are watching the show from. This is Your World, and my name is Winnie Lubem, and of course today we want to continue with a conversation that we started yesterday, and this is as far as TB or tuberculosis is concerned. And of course, like we said, we'll be celebrating, or the entire world will actually be marking World TB Day. That is on the 24th of March, will be on a Friday. So of course, again, we want to start the conversations earlier. Yesterday, we started the conversation on really trying to understand the disease, a little bit of the same, but of course, we'll continue with the same today and look at the situation right here in the country. So to help us with that conversation, we have a panel, who will be able to answer all your questions as far as TB is concerned. But before that, we all know that tuberculosis is the leading cause of death from an infectious disease globally. And this is, claiming about 3 lives every minute. That is the number that we should be thinking about. And it is curable and preventable, but unfortunately, access to diagnosis and treatment is often limited, leaving many people without the care that they need. So the question is, what exactly is the situation in the country, and have we made any progress? This is in the fight to end TB by 2030. That is the goal. Of course, we'll be talking about that. So let me introduce my panel. We are joined by Dr. Maurice Maina, who's the TB lead USAID Kenya. Asante sana for coming by today. You were here last year, right?
Yes.
More or less a time like this. Yeah. So it's good to have you again. Karibu sana.
Thank you.
And of course, we also have Peter Mushui Mungori, who's a End TB champion. It's so good to have you this morning. Karibu sana. And of course, we were also expecting the PS for State Department for Public Health and Professional Standards, and that is Dr. Josephine Mburu. But again, due to some circumstances, she's not able to join, but we'll be joined by Rhoda Paula, who's a program officer, National TB Program. She'll be joining us via Zoom, and of course when we have her, she will be part of the panel. But for now, Dr. let's just start with the basics, get to understand TB as a disease in itself, and then take a look at what is happening in the country.
Okay. TB is an infectious disease of the lung, mainly affecting the lungs, but can affect other parts of the body. People who get TB usually have symptoms of cough, weight loss, night sweats, lethargy. Sometimes they feel very tired. It's a chronic disease. It's a disease that we are able to identify in all the patients using the right tools. It's a disease that we can put patients on treatment, and when they take the medicines as prescribed for a period of 6 months, it is curable. Okay. Currently, it's a leading cause of death, the 4th leading cause of death among infectious diseases. We've been able to control it over the years. In 2016, when we did the prevalence survey, we found that we have about 140,000 cases in a year, but we were not able to identify most of those patients. So we started doing what we call active case finding, trying to look for these patients, putting them on treatment, and began closing the gap. In 2022, last year, we had an increase of over 10,000. We were able to identify over 90,000 patients who had TB, compared to the previous year where we had 77,000. Okay. So we feel that the progress that we are making, we are able to identify more patients, put them on treatment, and hopefully we will be able to eliminate this as a public health problem. Concern.
Absolutely. And again, we learned that TB can affect any part of the body except your hair, your nails, and your teeth.
Yes.
So then when it comes to the different other types of the body, I know the focus mostly is on the pulmonary, right? Yeah, but then again, these other ones, they're not as common, but it is possible.
Yes, it's very possible.
What does that look like? I'm just curious. For example, if I have it on my
on your
what
skin.
What does that look like? Yes.
Yes, the symptoms are very different from the symptoms that we get from the lung, and they are specific to the body parts. But we have like TB of the skin. You can get TB of the joints. You can get TB of the spine. Most of these types of TB initially come from pulmonary TB from the lungs, and then spread to other parts of the body. The key is identifying any type of TB and ensuring that we diagnose it early before it spreads to the other parts, and put patients on treatment so that we cure it.
Yeah, and we've made really, really great strides, and we've also seen innovations, especially when it comes to diagnosis and a bit of treatment here and there as far as TB is concerned, and especially mostly on diagnosis diagnosis, which we'll talk about as we continue with the show. But let's speak to Peter. So Peter, 2017 is when you were diagnosed with TB. And like you said, the normal TB.
The normal TB, right.
Okay.
Yeah.
So let's go back to 2017. What was it like? What were some of the symptoms, you know, that you had?
Okay, I can't tell the main thing, but I can tell how I started.
Okay.
I remember nilianza kukohoa tu kama kawaida. And then nikaenda kwa chemist kama kawaida, vile unajua Kenya tuko. Mtu akianza kukohoa kidogo ama maumivu kidogo anakimbia kwa chemist mtani. Yeah, unaignore tu, unaona kama sio big thing. And then nikakunywa madawa, nikakosa kupona, nikakataa kupona. And then
kunywa madawa for how long?
Dawa za chemist tu around 1-2 weeks.
Okay, I see.
Then after that nikaona imezidi. Kuliko niwe napona inaendelea. Okay. Then nikatembelea kituo cha hospitali ambacho kilikuwa karibu na mimi. Nilipopimwa nikapatikana niko na TB ambayo ilikuwa tu ni just normal TB. Okay. Na nikaanzishwa madawa kwa muda wa miezi 6. Okay. Then katika ile safari ya kunywa zile madawa mimi kivyangu sikuwa nakubali kwa sababu unajua watu wako na that mentality kwamba ugonjwa wa TB, ukiwa na ugonjwa wa TB uko na ukimwi. Nao hata kwenda hospitalini ilikuwa ni kazi. Hata kunywa zile dawa ilikuwa ni kibarua kigumu zaidi. And then nikiwa katika ile hali kwa sababu sikuwa nimekubali kitu ya maana, sikuwa nimekubali. And then after that nikaanza kuuliza mawaidha kwa different people kwa clinics ambazo ziko within. And then one of my friend akaniambia, was a clinician kwa chemist ambaye alikuwa karibu na mahali nilipokuwa nikiishi. Akaniambia hii kulingana vile nasikia ukikohoa hii sio TB. Unajua kuambiwa hivyo na wewe mwenyewe unajua hautaki kitu uko naye unafurahi. Nikafurahi na nikawacha matibabu. Nikiwa kwa on my third month. Oh, wow. Nikaacha matibabu. And then unajua ukianza as long as umeanzisha matibabu ya TB within 1-2 months unakuanga ni kama uko sawa. But yale maradhi hajatoka ndani yako. After 2 months ikaanza. Now ile ambayo ilianza iko ile ya kawaida. Kwa sababu ilikuwa ni MDR na ilikuwa very tough. Kwa sababu zile yale matibabu ya kwanza ya normal TB dawa zilikuwa chache sana. Zilikuwa ni kama 3 tablets. Ilikuwa tu ni rahisi. But kwa sababu ya kutokujikubali, unaona ile situation ambayo nilijipata nao ya MDR ambapo nilikuwa nikikunywa dawa 16 kila siku na sindano.
Oh, wow.
Hiyo ni back 2017.
Yes, 2017. Yes.
Now 2017. Haikuwa safari rahisi. Kumbuka sasa hizo uko na familia, wanahitaji kula, wanahitaji kulipa rent. Hauwezi sasa hiyo mwili umedhoofika, hauwezi ukafanya chochote. Nilikuwa mwanabiashara hapa Kikomba. Kuingia kuchagua zile mitumba pia ni ngumu kwa sababu ya hiyo harufu. Ukisikia una suffocate. Now ile safari haikuwa rahisi. Haikuwa rahisi, nikaendelea baada ya kumaliza masindano. Kufika mwezi wa, kwa sababu ilikuwa ni 9 months, kufika mwezi wa 8 nikadhani nimepona. Nikawacha madawa tena. Oh, wow. Na the reason why niliwacha madawa ni kwa sababu daktari ambaye alikuwa akikuja kunidunga sindano at least alikuwa anaficha ile situation. Yeah? Okay. Alikuwa anaficha ile situation, anakuja kwa nyumba, hakuna mtu ataelewa. Lakini nime kujipata eti nimeenda hospitalini kwenda kuchukua zile dawa ama kuchukua matibabu yangu inakuwa ni mzigo. Sitaki watu wajue. Una understand? Kwa sababu kulikuwa na stigma. Nikitembea watu wanaanza kunidhalilisha, wananiambia Peter uko na ukimwi, Peter umeisha sana. And remember I'm a musician. Na nimekuwa nikiimba kwa makanisa, nimekuwa mwimbaji. I can remember even my friends, they left me. Even those pastors, they left me. Yeah. So now you can tell the friends ambao walikuwa karibu walikuondokea. Then wakati unakuona unaenda hospitalini kwenda kuchukua zile matibabu pia wanakucheka. So ndikasababisha mimi mara ya pili nikakosa kwenda hospitali. Maana yule daktari alikuwa akiniletea madawa, akikuja kunidunga aliacha kukuja kwa sababu nimebakisha tu madawa, nitakuwa nikifanya nini? Nikienda kukuja hospitali, nikienda kunyia hospitalini. Nikawacha. Na nikatulia sana, nikakaa miezi kama 4. Vizuri tu. I remember wakati nilirudi sasa ile MDR tena, nilianza kukohoa. Vitu ambazo zinakaa kama cholesterol, mafuta ile cholesterol. Yeah. Na wakati unatoka ukishika, unasikia ni kitu ambacho kinanuka vibaya sana. Hapo ndipo nika realize hii kitu iko niondokea. Nikanianza na uzito tena. Na hiyo ni mara ya pili. MDR now. Na wakati ilinianza mara ya pili, hiyo naweza kukubali. Kwa sababu ile stigma bado. Nilijaribu kuconvince my parents kwamba hii sio TB. Nilijaribu convince watu kwamba nilimaliza ile dawa. Now this is another thing. Hii sio TB kwa sababu sitaki kuikubali.
Ya kwamba ni TB.
Yeah.
Hey, okay. Can we just pause on, this is the second time umeacha kumeza dawa.
Yes.
And Daktari, very quickly before we speak to Rhoda, because she's joined us via Zoom. Rhoda Paula is the program officer, National TB Program. Very quickly on man, it's a lot. So, so the normal TB, 2 months in, amemeza dawa, and then stopped, and then now, you know, got to that point of multi-drug resistant TB. Could you just speak on that?
Yes.
The MDR.
Yeah. You know, TB, as I said initially, is curable.
Yeah.
But for it to be curable, a patient has to take the drugs as prescribed on a daily basis for the duration. Initially, it's the 6 months. If you stop anywhere before the 6 months, then you have a probability of TB coming again. And this is a clear example of what happened. The first 2 months, we call it intense treatment. That's when we get out, we make sure that the TB gets out of the system, and then we continue to make sure that, you know, it's completely out of the system for the next 4 months. And if you stop anywhere within the 6 months, then it will come back again for sure. And if it comes back again, it could come back as the normal TB, or it could now be a drug-resistant TB. Because if you don't kill the TB in the system, it comes back when it is resistant to the drugs that we normally use. And therefore, we have to change that to multi-drug resistant TB treatment, which requires more drugs, more expensive treatment, and a longer period. Those drugs have more side effects, and that's why you can hear him saying that, a bit of more of nausea and a lot of other side effects that he gets. So once he is on multi-drug resistant TB, he should continue on it for the 2 years, which we were doing previously. But now we're changing this to be 1 year, and we're also removing the injections bit, so that the drugs are more acceptable to the patient, they have less side effects, and they're able to complete the treatment. Of course, when he stops taking drugs for multi-drug resistant TB, there's another risk, and the risk is he gets extremely resistant drug TB. That is even harder to treat, more expensive, and the success of treatment is worse. So we urge our patients, anyone who has TB, to make sure they take the treatment to completion, even if they feel better. They'll start feeling better and start asking, why should I take the drug? I mean, you know, there's stigma around it, so they stop taking the drug. We urge them to continue taking the drugs. For drug-resistant TB, what we have encouraged and what we've done is to ensure that the healthcare workers go to the patient's home and provide the treatment there. We call it directly observed therapy. We do that to ensure that this patient takes the drugs every day. And if we reduce the patients that we have on drug-resistant TB, the burden of TB would reduce, and people would be able to live their normal lives.
Absolutely. And I'm happy that you pointed that out, because again, there's the normal TB, and then there's drug-resistant, then multi-drug, and then extreme. And you do not want to get to the extreme part. I know taking the medication, there's that aspect of fatigue and exhaustion, but just try. And I'm happy that Peter says, listen, Yeah, I tried nilishindwa because of the stigma, you know, from external forces and also from within. But I'm happy that you're here today, you know, to really help us understand what that looks like. Let's speak to Rhoda, and then we'll come back to you, Peter. So Rhoda Pola, like I said, Program Officer, National TB Program. Thank you so much for joining us via Zoom this morning. I don't know how much of the conversation you've caught up on, but I just want you to paint a picture for us. What are we dealing with in the country as at now? What is the situation? What is the prevalence, you know, of TB here in the country? And what exactly are we dealing with? Are we dealing with a case of drug resistant, multi-drug resistant, or extreme resistant type of TB?
Thank you very much. Good morning. Kindly confirm you can hear me.
Yes, we can hear you.
Great. So I joined the discussion a few minutes ago, but at least I've caught up with the discussion. So from the Ministry of Health point of view, the country notified 90,841 cases of TB last year, that is 2021.
All right.
This was a 16% increase as compared to what we notified in 2021. Those are the DSTB cases, drug-sensitive TB cases. In regards to the number of drug-resistant TB cases, last year we notified 752 cases. Again, this was a drop as compared to what we had notified in 2021. So as a program, we are handling both cases. We're handling both DS and DRTB cases, DSTB being the majority. And we have seen an upward trend of DRTB cases. But last year was fairly challenging. We had some challenges in regards to the diagnostic techniques to help us diagnose DRTB. So that is where we are at the moment.
All right. When you say a bit of a challenge, you know, and especially when it comes to diagnostics, what exactly does that mean?
Okay, so for us to diagnose drug-resistant TB cases, there's some tests that you have to perform in the lab. There's a test called Gene Expert. We also have another one which is quite new. It's called TrueNut. And we also have culture. So all these are molecular tests that can help us pick TB first, yes. So you'll get the result that TB has been detected. But on top of that, it's able to tell you the resistant pattern, that this TB is resistant to the following drugs. So that is how you know that you're dealing with a case of drug-resistant tuberculosis. So last year, there are some of the lab commodities that for a long duration of time in the course of 2022 that were not available in the country. And this caused somehow drawback in terms of picking these drug-resistant TB cases.
All right. We'll come back to you to then understand. So what are some of the measures that the government has taken just to make sure that, you know, you deal, excuse me, with that particular challenge and where we are now, and especially when it comes to like innovations and, you know, also with the help of partners, like you were saying, you know, to make sure that diagnostics are done in time and also, you know, the whole aspect of patient tracking. But for you, Peter, so the second time, umeacha kumeza dawa, and compare your symptoms the first time and now that umeacha kumeza dawa for the second time. How was your health? How were you doing at this time? Because you had deteriorated kabisa, you know, during this first time, and also that brought about stigma from external, na acha pia wewe ulikuwa just stigmatized, yeah? Like huko umejikubali.
Yeah, right. Kwanza ukiwa na TB sana MDR, kusema kweli hata kutembea ni shida. Uwezi ukapanda stairs, uwezi ukatembea sehemu ambayo unapanda kwa sababu una strain kifua, unahema kwa sana. Na haikuwa kitu rahisi ambacho kilinisababishia, kwa sababu kusema kweli nilisumbua watu wengi, nilisumbua wazazi, nilisumbua familia. At that time I remember, kwa sababu ya that kujikataa ama kutokujikubali, nimetumia hadi inhaler. Nilitumia hadi inhaler kwa sababu nimepelekwa na wazazi, wamenipeleka mpaka Kenyatta kuangaliwa kifua. Ninafika hospitali na danganya madaktari, nawaambia no, this is not TB, kwa sababu nilitibiwa na ikaisha, na ikapona. Una understand? Ile nayo ni kukataa. Yeah, na una convince madaktari kabisa na nakubali. Unawaambia hii nimetibiwa. Ninaambia mzazi namwambia waambie nimetibiwa. Nao nakumbuka Kenyatta kuna wakati nilipimwa nikaambiwa nao kama ulitibiwa TB na ukamaliza madawa basi hii itakuwa ni asthmatic. Na nikapatiwa inhaler.
Okay.
Na nikaanza kuitumia. I can tell you baada ya kuanza kutumia inhaler hali yangu sasa ikakuwa mbaya zaidi. Nikajua hapa naenda kufa. Sasa hiyo kumbuka nina familia. Yeah. Nao ukombozi wangu mahali ambapo ulitoka ni mimi mwenyewe sasa ilifika mahali nikajikubali.
Okay.
Nikasema this is my life. And I'm not ready to die. Niwache familia yangu ikihangaika. Nao ndio nikarudi hospitali mahali ambapo nilipimwa mara ya kwanza. Nikamwambia nao mimi sikumaliza dawa. Munipime tena.
Yeah.
Kupimwa tena. Wakaniambia nao uko na MDR tena TB.
Okay.
Na I thank God kwa sababu dawa ambazo nilizokuwa nikizitumia hapo awali zilikuwa ni mingi. Kwa sababu nilikwambia tulikuwa tukitumia tablets mingi na sindano.
Yeah.
Nao pia ile kudungwa hizo sindano kila wakati zilikuwa na side effects mob. Kwa sababu kidungwa ile sindano saizi huwezi ukaona. Unadungwa na unalala.
Okay.
Una understand? Haikuwa rahisi. Now the third time now wakati nilikuja kujikubali na nikaamua sasa this is my time. Lazima nikubali sasa. I thank God kwa sababu zile dawa ambazo tulikuwa tukitumia zilikuwa zimepunguka kwa sababu zile dawa ambazo tunatumia saizi ambazo zinatumia za TB saizi ni dawa chache. Hata kama miezi ni mingi.
Yeah.
Hata kama na kwa sababu tunaenda for 18 months na kama maybe ujapona unaweza kaendelea kidogo. Naweza nikasema ni dawa ambazo ziko sawa.
Okay.
Yeah.
Yeah.
Now,
so vile ulienda ukajikubali ukasema listen sikumaliza dawa.
Yes.
Nipime tena.
Yes.
And then they put you on treatment. Ulipewa so ulikuwa na meza dawa ngapi? Bado ulikuwa na meza 16?
No.
Okay.
No. Saizi zimepungua.
Yeah.
What I can say now dawa za TB zimepungua.
Okay.
MDR. Na kwa sasa sioni sababu ya watu kuendelea kufa ama kuendelea kusafa kwa kifua kikuu. Kwa sababu matembe ambazo zinatumika saizi ni dawa tu za kawaida. And then hazina that side effects mob. Una understand? Ni dawa ambazo unaweza kunywa na ufanye kazi yako. Bora tu shibe.
Okay.
Bora tu shibe.
I like that. And I like the fact that we point that out because majority of the times patients would say I am expected to adhere to a healthy diet, but then sometimes sipati, you know, I am struggling to first of all pata pesata za kwenda hospitali and all those things. TB treatment is free, right, in all public facilities, but then again you know cost your transport if you're not you know isolated, and then you have to at least make sure umekula 3 meals you know in a day, a healthy meal to at least help your body to also deal with it, which is mostly a challenge. So I think we'll come back to you to understand. So then how did you manage? How long did it take kabla uambiwe sasa wewe umepona? You can go back to your life, and how was it even adjusting? But we'll also talk about you know some of the challenges as well, especially when it comes to diagnosis you know of TB and some of the innovations that have been there as well. But if you have a question at NTV Kenya, both on Facebook and on Twitter is how you can reach us, or better yet, give us a call. The numbers are down on your screen. And of course, we'll be talking more on the same after the break. Stay with us. This is Your World.
Choose boldness. Celebrate the skin you're in and dress with confidence with Nivea Nourishing Cocoa Body Lotion. The triple layered care of deep moisture serum, precious cocoa butter, and vitamin E enriches your skin for 48 hours. Choose to wear your skin with pride with Nivea.
Own your dream home for as low as 1.98 million Kenya shillings in Vipingo, Kilifi, and enjoy a flexible payment plan of 10% on signing of the letter of offer and the balance in equal monthly installments within 18 months. Supported by world-class amenities and infrastructure, our estates offer a unique, secure environment with a wide range of outdoor facilities. SMS Vipingo to 22365 or call us today on 0740 400 215. Terms and conditions apply.
Is your business looking to expand to new markets? Welcome to the Democratic Republic of Congo, the solution country with consumer base of 100 million people, a capital city of 15 million inhabitants, the second largest city in Africa. The Nation Media Group, through the East African brand, is proud to present the East Africa Business Conference and Trade Fair on the 30th and 31st March in Kinshasa, DRC. Join us at this special event where businesses from across Africa will gather to network and build partnerships with enterprises in the DRC. With a theme of searching for new markets and partnerships, this is the perfect platform for you to showcase your innovation, discuss new markets and partnerships, meet key officials, and secure your new connections. Sectors represented include real estate, banking, agriculture, healthcare, retail, mining, and many more. For more information, contact Timothy on 0703 208 909 or email timudengi@ke.nationmedia.com.
Santon, a fun new world of flavor. Fruity freshness in every sip.
With Glovo, you have anything you want from your city in your hands. Kama unatamani ugali beef ama fried chicken, order Glovo ujaribu restaurant mpya. Tamu. Kama game inawaka na unataka drinks zaidi, order Glovo ushangilie timu yako. Na kama your little one amemess na diapers zimeisha, order Glovo and save the day. With Glovo, unaweza track order yako na kuongea na customer support, which is always available. Download the app and order anything you want from your city. We'll deliver.
Welcome back, beautiful scenes over there. Jackson says that's what Tarakaniti, beautiful. Okay, all right. Welcome back. Let us stay with us. The show is Your World, and of course, it's all about a very important conversation that honestly we all should be talking about, and that is as far as TB or tuberculosis is concerned. But at the same time, have the correct information so that we all help in fighting stigma that comes with the same. So today we want to understand how are we doing as a country, because we're preparing for the World TB Day, which is to be marked on Friday. That is on the 24th day of March, and this happens every year. And yeah, have we made progress? Because remember, there is a goal that is to end TB by 2030. So how are we doing as a country? And before we go back to Rhoda, very quickly, let's take a look at some of the numbers, what the numbers look like, as far as TB is concerned in the country. Just a quick reminder that, yes, World TB Day, 24th March is when we'll be marking the day. And it remains an epidemic in most parts of the world, causing the deaths of nearly 1.5 million people each year. And this is mostly in developing countries. And remember the number that we talked about, 3 people every minute, either lose their lives to TB. And of course, there are 2 types of TB-related conditions, right? We have the latent TB infection, and we also have the TB disease itself, and that is the active phase of the same. So what do the numbers, again, it is curable and preventable, something that we really, really need to, but at the same time, people are dying from the same. So according to the Ministry of Health, 90,841 TB cases were reported in 2022 compared to 77,854, and this is in 2021. And at the same time, it's actually regarded as the 4th cause of death among infectious diseases right here in the country. So the big question is, what can we do? Because like we said, we all have a role to play as far as eliminating TB. And this is, remember, the goal, and that is the 2030 goal, that we will not be talking about TB come 2030. So where are we? What are we doing? As far as that is concerned. So let me bring in Rhoda very quickly. You talked about a bit of a challenge, especially when it comes to diagnosis, but so what are we doing now? How are we doing? What are some of the diagnostic models that are used in the country to diagnose TB?
Okay, thank you very much. So the challenge that was there in large part of last year has been solved. Most counties have confirmed now they have received the commodities that were missing for diagnosis of drug-resistant tuberculosis. And so regarding your question on which are the available diagnostic options, there are quite a number. TB space has a lot of innovations and a lot of research happening each day. So earlier in the days, we used to have a test called microscopy. Microscopy, we can call it old school way of picking TB because the process is manual. You're not able to know the resistant pattern of the TB that the patient is suffering from, but it is still very commonly available and in use. So some of the newer tests that have come in place is the Gene Expert. I think it's been in the country for quite some years now. It's a molecular test and it's able to pick the presence of the TB bacilli and also the resistant pattern, but specifically for one disease or one drug, which is called rifampicin, which is a key drug in the treatment of tuberculosis. In addition, in partnership with some of the stakeholders that support TB in Kenya, they have been, USAID specifically here, they've procured for us TrueNut, which is equally a molecular test, and it can serve best in the rural areas where you do not have a lot of working space. You do not have maybe a constant supply of power. So it is very effective in instead of ferrying samples from the rural areas to where you have a Gene Expert site, the TrueNut came in handy. And here we have, I think, about 38 TrueNut machines in various counties in the country. And this also does what the Gene Expert does. We have chest X-ray, which has been there for some time. It can help in diagnosis of TB, and specifically the TB diagnosis among children. The good thing about the current X-ray machines that we have, again, that we have procured with the support of the different partners that support the Ministry of Health, we have a digital X-ray that can help a clinician or the doctor managing the patient to know that I am dealing with the case of TB. Unlike the old X-rays where maybe the clinician will have to read or wait for a report. So this one can be done very fast and also help initiate the patient on treatment early enough. So these are some of the commonly available diagnostic options that the healthcare workers in Kenya have to diagnose TB.
Okay. And how much of an impact would you say that has made, especially when it comes to diagnosis of TB in the country, using some of the latest innovations?
Okay, like you said, comparing 2021 and the data we had in 2022, despite the challenges, we were able to observe an increase in TB cases. And just to mention, some of the digital X-rays that we have are very portable. So the counties can choose to pick a TB hotspot or an area where they're suspecting that most of the TB cases could be coming from that area and conduct a targeted outreach. So here the community will be mobilized to come out, to get screened, to get tested, and in a way that has also contributed to the number of cases we have diagnosed in the country so far. And as you had mentioned, some of the strategies to end the disease, WHO clearly states that for you to end any disease, number one, you have to ensure that anybody that could be having the signs and symptoms gets investigated. And if they're found to have the disease, then they should be put on treatment very fast or as soon as possible. And that is how that's the focus that the country is taking to ensure that we avail all possible diagnostic options to ensure that the common mwananchi can get to know that they have TB early enough and start on treatment in good time. That way, even the outcomes that they will get at the end of treatment will be better.
Absolutely. All right, and Dr. Morris, do you want to contribute as well, you know, to the innovations, diagnostics, and how much of an impact it has made in the country?
Okay, thank you. As I said earlier, we are missing about 40% of the patients that we should be putting onto care.
Yeah.
And as Rhoda said, the first thing we need to do is to find out where these patients are.
Yeah.
And I think part of the issue we've been having is access to the diagnostic tools. So we want tools that are able to go to the lowest level health facility, to a dispensary, to a community health setting. And that's why we introduced the TrueNut that are battery operated. They don't need power, they are portable. You can take them to where the patients are and be able to diagnose the patients. The portable digital chest x-ray that have artificial intelligence, that once you do the x-ray, then somebody seated somewhere can be able to find out whether that is TB or not. So if we have these tools everywhere we have pots of patients, we'll be able to bring those patients into care. And with that, then we do what we call active case finding. Any patient who is coming to a health facility who has a symptom like a cough, let's check what that cough is. Let's take them through a test. And then if we're able to get all these patients, the second prong of that is that can we put them on treatment? Can we cure them? That has two aspects: making sure everybody gets onto treatment. Secondly, ensuring that they complete onto that treatment. And thirdly, ensuring that they have quality of care, and we fight the issue of stigma when they're on treatment, so that we support them to finish the treatment. The third prong would be prevention. When these patients are at home, how do they how are they living with their other household contacts? Can we get the people they live with at the home to be tested for TB? We know TB is spread through the cough. So if they're at home, if we are all of us living in one household and one of us has TB, it's probable that each of us will get TB. So we need to come to that home, test everyone for TB, and ensure that they don't have TB. If they don't have TB, we can put them on TB preventive therapy. This is a therapy that cures or treats the latent TB, so that those people who are under high risk, we are able to put them on TB preventive therapy. This also includes people living in the prisons, and also includes our healthcare workers. Our healthcare workers, like the ones who are treating him, are also at risk of getting TB. If we can be able to detect TB in them early and also put them into treatment, then that will help us move towards ending TB. And then building the systems that help us prevent and cure TB, improving the capacity of our healthcare workers to have high index of suspicion, to say that this could be TB. Working with the private sector, we know, like him, he went to a private healthcare facility when he had a cough. He did not go to a public health facility. Where you heard what he said when he went to the pharmacy. He was given some drugs for 2 weeks. Most of our patients who come into, whom we find that have TB, over 60% of them first seek healthcare in a private health facility. And they don't get correctly treated. And they stay with this TB for another 2 weeks, for a month, before they then come to a public health facility where they get diagnosed for TB. I think it's important for people to know how TB is diagnosed, where they can get treatment, and if they have a cough, even if they get the antibiotic for the cough, if the cough doesn't go away, they need to come for testing so that we can put them on treatment.
See what exactly they're dealing with. Okay, I'll come back to you to really understand. So then the importance of collaboration, because again, like Rhoda said, yes, the government might do, much, but, without the support. And this includes us as a people, first of all, to understand the disease and the prevention and all those things. And then, other partners coming in to collaborate to make sure that we end TB by 2030. How does that improve the same? But for you, Peter, so the second time, I want us to fast forward to the third time, where again you were diagnosed for MDR, and did you suffer like any complications?
No.
Okay. All right. You did not get any complications during the treatment process.
But to side effects.
Side effects to kidogo. Okay. All right. So the third time, what did you do? What happened when you stopped taking your medication, and how did your life change? Because, like you said, your friends deserted you. It took a while before ulijikubali, and also that long period of treatment and all those things. So maisha yako ilibadilikaje? How were you affected by the disease that is TB?
Kwanza maisha yalirudi chini. Kwa sababu kama vile nimekwambia nilikuwa mwanabiashara. Wa kuuza nguo za mitumba, nilikuwa nikiuza Tanzania, Kenya. Kwanza hiyo biashara ilisha kwa sababu siwezi nikahudumia customer kama nakoa. Then unaelewa hizo side effects za dawa, unadungwa sindano kila wakati. Una understand So maisha yalirudi mpaka nilirudi chini sana kimaisha, nikarudi nyumbani. Hata kama nilikuwa nikiishi maisha fulani, nilirudi chini kiwango kikubwa zaidi. Ilifika mpaka mahali karibu nifikiria kuuza vitu za nyumba. Lakini kwa sababu kulikuwa na sehemu ya kutorokea nyumbani, nilitoroka nyumbani. Kidogo nikakaa mbali na Nairobi. And then wakati nilipata nafuu ndio nikarejea.
Okay. Could you just speak on support and how important you know, support is?
Kwanza ningependa kushukuru sana the NGOs kwa sababu wanatusaidia sana. Kwa sababu every month tunapata kitu kidogo at least ya kutuwezesha kupata maybe kitu ya kula ama maybe kujisimamia sehemu kidogo.
Okay.
Yeah.
Yeah. Now, so how then were you able to manage? Because like you said, as long as umeshiba,
as long as umeshiba,
right?
Yes.
You're able to take your medication. Na haita kudhuru sana.
Yes.
So for you, how were you able to do? What are some of the things that you ulikuwa unakula sana? You know, zingine maybe una reduce kidogo.
Yes.
You know, just to make sure that your body is able to take in you know, the medication that you're given.
Kwanza ni kuna wale watu ambao wanatuelekeza jinsi ya kula vyakula ambavyo vinastahili katika miili yetu.
Okay.
Sana tunatumia matunda. Yani zile chakula ambazo ziko na nguvu ndizo tunafundishwa kuzitumia. Na wakati unaanza kunywa hizi dawa, naweza kuambia kuna appetite. Unapata appetite zaidi.
Unapata appetite. Okay.
Unapata appetite sana.
Yeah.
Now ukiwa na that appetite and then ukose chakula. Alafu bado unastahili kunywa zile dawa. Now you can tell now that situation will unaweza ukawa. Chakula chakula as long as umepata chakula katika mwili wako na unatumia hizi dawa, naweza nikakwambia utakuwa sawa.
Okay. So then at what point uliambiwa sasa wewe umepona? Because again like you said, ilifika point ukajikubali na ukasema this is my life, I have my family to take care of. You know, and I need to get better for them. So at what point were you told sasa umepona? And because like you said, I mean longer period, like 18 to almost 20 months. So you were on drugs for, I mean not treatment for 18 months. So at what point were you told, hi, umepona, now you can, you know, go back to your life?
Ilikuwa ni December.
Okay.
Ilikuwa ni December last month.
Okay.
Ndio.
Last year?
Yes.
2022. Okay.
Ndipo niliambiwa nimepona, nikafanywa vipimo mara kadhaa. Na nikaonekana kwamba imeisha.
Okay.
So wakati unamaliza matibabu yako, si tunaachiliwa tu kwa sababu umefikisha 18 months. Bado unafuatiliwa. Bado unafuatilia matibabu, unafuatilia vipimo, unazidi kupima mara kwa mara hadi wakati daktari mwenyewe atakwambia nao uko sawa. You're good to go.
Okay. All right. I'll come back to you to understand. So how are you doing right now? Because I think during the break is when we were discussing ukasema when they did what, an X-ray, one side of your lung, you can kama moshi. And then this other side. So Dr. tell us what exactly that means. But let's speak to Rhoda very quickly. So Rhoda, what are some of the treatment protocols you know, here in the country? You know, maybe you have mentioned one or two, you know, or three here and there, but what are the treatment protocols as far as TB is concerned? Because now we're not doing the injections, right?
No, we're not doing the injection. So starting with the drug-sensitive TB, when one is diagnosed with a drug-sensitive TB, they are put on treatment for 6 months. And they're expected to take medication on a daily basis.
All right.
The good thing, it is once a day. The number of tablets will depend on your weight. So the maximum is 5 tablets for the ones that are weighing 70 kgs and above. But as the weight goes down, there are those that will take 4 tablets, 3 tablets, 2 tablets, and the likes. And this will go for 6 months.
All right.
For drug-sensitive TB at the moment, earlier on, we had injections, as you said. The injection used to be given for about 8 months in the intensive phase, and then the remaining months they will take tablets. But at the moment, most of the patients that we have are on only tablets. They're expected again to take them on a daily basis for the specified period, as our client has mentioned today. The difference between the treatment for DR TB is that the drugs are not fixed. They're not put together. So if it is a drug going by this name, you'll have to take that drug, the number of tablets according to your weight, the second drug the same way, the third drug the same way. So at the end of the day, you'll hear patients telling that I have a whole 15 tablets to take. Yeah, but because that is because we do not have them in fixed dose combination. But support is really given by our healthcare workers to ensure that they visit these patients at the household level to support them. And should they experience any side effects, they'll be there to support them and also manage the side effects. So all TB medications are taken once a day. And then for the specified period of time according to your weight.
Okay. All right. And again, so COVID-19 came and it brought about a lot of destruction, in several areas of our lives. Almost everything sort of like came to a standstill. So how much of an impact would you say COVID-19, brought in, especially when it comes to TB diagnosis and treatment in the country?
Okay, the year 2020 was a very challenging year to the management of TB. Number one, you will remember that anybody experiencing signs and symptoms of any respiratory signs and symptoms were thought to have COVID, and they will be picked and isolated. So that in a way made people that were experiencing the signs and symptoms of TB fail to come out of the hospital. So number one, diagnosis was delayed. And once diagnosis has been delayed, it means transmission is happening at the community level.
All right.
Number two, you will also remember that there was a lot of movement at that time, people wanting to relocate back to their rural areas because they're not going to work. So some of the patients that we had on care, maybe in some specific towns, were relocating to their rural areas. That meant that they discontinued seeking care. And then just the opportunity of coming to seek care, the workload went down, meaning that we could not diagnose these patients, we could not put them on treatment and the likes. So if you look at our numbers in the year 2020, we had a much drop as compared to what we had notified in the previous year, that is 2019. But as measures were put in place, care for COVID, people came to understand how to take care of COVID patients, how to differentiate the different symptoms of these two diseases over time, and up to where we are now. People have now people are now coming out to seek care whenever they're experiencing signs and symptoms, and hence the increase in TB cases from 2020 to where we are at the moment.
Okay, and then can you quickly comment on the role of community health workers play, and especially when it comes to the whole question about prevention and control at the same time, because I think Peter mentioned as well a bit of the same in terms of how important they are. Come talk to you and see how you're doing. Are you adhering to your medication and all those things?
Yeah, so the Ministry of Health has invested heavily on our community health volunteers. These ones are very supportive at the community level. We use them to provide health education and creating awareness of TB at the community level. For the people to understand what are some of the symptoms in an easy way, they will get that from the community health volunteers. So they provide the health education. And if anyone is experiencing the signs and symptoms of tuberculosis, they will refer you to the health facility for investigation. And if you're not able to do that, they will also support you by providing some of the sample collecting, sputum collecting equipment, so that they ferry the specimen for you to the health facility for investigation. Once TB has been diagnosed, the community health volunteers play an equally key role in supporting. They provide we call them our treatment supporters. So they will visit TB patients on a regular basis to ensure that, number one, they are taking medication, and if they're experiencing any side effects, they will report that to the health facility. They will support the patient to report some of these side effects they're experiencing to the health facility, and in that way, then the patient will come to terms with whatever they're experiencing, and it will be managed. And then we had Dr. Morris had also mentioned about TB preventive therapy. So when we diagnose a patient with TB from the lab, we expect that the household members, the people that this patient is living with, will be also assessed. They will be screened for TB. So it is the role of the community health volunteers to ensure that the family members, number one, understand that they're dealing with a TB patient and they're also at risk. So they'll provide that health education and also refer these patients to the health facility for further screening by a healthcare worker, and also for initiation of what we call TB preventive therapy, so that in future we do not treat another family member with tuberculosis.
Absolutely. All right, I'll come back to you. Okay.
You had also mentioned that is one way, the TB preventive therapy. But also we have other measures which are specifically addressed to the patient that we're dealing with, to ensure that they observe cough etiquette, they have adequate ventilation and the likes. In the same way at the health facility, also to make sure that the healthcare worker is safe. There are also some prevention measures that the healthcare worker has to take to ensure that they are not at risk of being infected with TB.
Okay, so I'll come back to you to understand. So this year, excuse me, do we have plans from the Ministry of Health and Disease as far as marking the day? Where will it be? But very quickly, Dr. Morris, in terms of collaborations, like we said, because this is a collective, effort among health workers, we as a people, the ministry and all those things, and even partners as well. And how much of an impact will this have, especially when it comes to the road to ending TB in 2030?
Yes. TB is a disease that requires several sectors to play a part in. And, tomorrow during the World TB Day, we'll be launching the multi-sectoral framework. That is a document that says what are the role of the different partners in TB. We as donors, as US government, has worked in this country for long, having a long partnership in TB and also TB HIV. And when we look at the data now, we're able to see the progress and the impact that we have made. The other donors, there's Global Fund, there's WHO, all these work together. We have a national strategic plan for TB that has various partners that play in it. We've now expanded from seeing this as a disease that only needs to be dealt by the Ministry of Health. We have Ministry of Agriculture, we have Ministry of Education, and all these taking this disease as a sectoral approach, then we'll be able to work together and be able to fight it.
By 2030, hopefully, even before, hopefully, before we get to 2030. Okay, and Peter, what would you tell people? I mean, having gone through this journey and the entire period of treatment, and now you're here, and like you said, once you remember, you can go home, you're okay, and all those things. It doesn't end there. Of course, there are a bit of follow-ups, here and there, just to make sure that uko sawa. So what is it? And also dealt with stigma, both self and also from the people outside. So what would you tell the people who are watching us, whether they're TB patients, whether they are just caregivers and family members, friends, and everybody around? What would you tell them about the disease, very quickly?
Wow. TB iko na tiba. Hiyo ndio kitu ambacho naweza nikatangulia kusema, na watu wetu kwamba waelewe TB iko na tiba. Na TB ni ugonjwa kama yale magonjwa mengine tu. In the last few months, tangu nimalize madawa, nimekuwa kwa streets za Nairobi. Nimekuwa different places. I think sijui kama kuna kona ambaye sijui
ujaingia.
Most of the people wananiita ule jamaa wa TB. Because siwezi nikakubali ama siwezi nikafurahi wakati ninaona watu wetu wanakufa na kitu ambacho kinaweza kikapata tiba. Kitu ambacho kina tiba. Nimetenga siku zangu za wiki. Nimetenga siku 2 za wiki. Na Sunday pia ni siku ambaye baada ya church ninahubiri about kumaliza stigma kwa TB. So watu wakielewa TB ni nini, tutapunguza vifo. Na Vision 2030 TB itakuwa imeisha. Kwa sababu kitu ambacho ningependa kusema ni kwamba makali ya TB hayaui zaidi ya stigma. Stigma ndio imefanya watu ambao kuna TB wanajifungia kwa manyumba, wanakataa kutoka kwenda kufuatilia matibabu yao. Na ndio maana tunapokea vifo vingi za TB. Na TB haitakoma kama NGOs na the government kama hawata support watu ambao kuna ujuzi kama sisi. Kwa sababu I can say the truth, sisi watu ambao tumejitoa, kwa sababu now you can ask yourself.
Okay, very quickly, like 10 seconds kabla tufukuzwe.
Yes. Now, for example, nimepona TB. Sasa hizi kwa simu yangu niko na group za watu ambao wamepona TB. Nairobi, Baringo, nimekuwa Baringo, nimekuwa Kitale, nimekuwa Kirinyaga. Next week niko side za Nanyuki. Nimekuwa nikitembea kila mahali. Na hawa watu ambao wanatibiwa TB wanapona, wanapotelea wapi? You understand? If they can get support, wanaweza wakatoka nje. Na hao ndio wanaweza kuwa kipaumbele kuweza kustop TB.
I like that.
Yes,
I like that.
So
you
use that experience.
You know, absolutely.
Yes.
And tell people about TB. Thank you very much, Peter. Jack, so only ask for 30 seconds to ask, you know, Rhoda, very quickly, where will we be marking the day this year as far as TB is concerned, which is tomorrow? Very quickly, like 10 seconds.
Okay, this will be commemorated in Eldoret, Uasin Gishu County.
Okay.
Yes.
Everybody needs to come out. I mean, if you're in that area, or if you can get yourself there, please go and mark the day. And this is in relation to the theme, and that is, yes, we can end TB in the country. So, asanteni sana for coming by today. I know time is not on our side, but we have to say goodbye. Thank you very much, Dr. Maurice Maina, TB lead, USAID Kenya, Peter Mushui Mungori, and TB champion, as well as Rhoda Paula, program officer, National TB program from the Ministry of Health. Asanteni sana, and I know that you've learned a lot from the conversation today. Now the ball is in our court. We all have a responsibility as far as ending TB right here in the country. So let's just do our part, okay? And especially when it comes to addressing the stigma that comes with the same. So have yourselves a lovely day ahead. I'll see you on Monday, same time, same place, right here on Your World. But until then, enjoy your weekend, stay safe, and remember to, you know, let's fight stigma associated with tuberculosis. Goodbye for now.